and then you can take over whenever I'm done with my introduction. Okay, good morning and welcome to Pediatric Grand Rounds. We had to go to a lot of technical difficulties this morning, but finally I think we are on here. Please complete the evaluations after the presentation, and we will keep posting the CME credits in the chat box, the number for the CME credits in the chat box. Frequently, don't have to send me a reminder. It's my great pleasure to introduce this morning's Grand Round speaker, Dr. Milind Pansare, who is a good friend of mine. He's an associate professor of pediatrics at Central Michigan University and Children's Hospital of Michigan. He received his MBBS degree and then did his MD in pediatrics from Bombay University. Now it's Mumbai University in India. Then he moved to the US and did his pediatric residency at Henry Ford Hospital in Detroit and fellowship in allergy and immunology at Children's Hospital of Michigan. Subsequently, he served as the Associate Fellowship Program Director for Allergy Immunology Fellowship Program and also Medical Director for Asthma Program at Children's Hospital of Michigan. His clinical interests include asthma, anaphylaxis, and food and drug allergies. His clinical research projects include improving asthma outcomes in inner city children and anaphylaxis education in local schools, as well as improving access to rescue inhalers and epinephrine autoinjectors in inner city schools. At the national level, he's very active in numerous activities, including educational, scientific, and advocacy activities for the American Academy of Allergy, Asthma, Immunology, and the American College of Asthma, Allergy, and Immunology. Dr. Pansare, thank you very much for accepting our invitation. The floor is yours.
Oh, thank you, Dr. Kamath, for your kind introduction and giving me an opportunity to engage with your faculty today. First of all, good morning, everybody, and I'm wishing you a very happy Friday. You know, today is a special Friday. Today is April 11th, and guess what? Today is the International Cheese Fondue Day. Do you know what it means? It means that we can go raid cheese factory, go to Mexican restaurants, American burger places, and eat cheese to our heart's content and enjoy. Isn't that a wonderful thing? But imagine a world, living in a world where even the most innocent food could trigger life-threatening reactions. And there are really many patients out there who cannot eat these innocent food because they develop a serious and a severe reactions. This entity is not very uncommon. We often would miss that if we have no knowledge about these entity. So today, my goal is to bring your attention to one of such clinical syndrome which can potentially result in severe clinical reactions. Nope, I'm not talking about anaphylaxis. We know about anaphylaxis. I think we do a good job in taking care of patients with anaphylaxis. But I'm talking about a rarer entity. Imagine patients living in a world having this disease syndrome, and we're living in a constant fear, anxiety, worried about when that next reaction could occur. I'm not making it up, it is real. This disease was not discovered until very recently. In 70s and 80s and 90s, many of these patients were not diagnosed appropriately. When they went to see a doctor, who would often give them an advice which was inconsistent with the clinical symptomatology. Often they were told, I don't think food is responsible for this. I've never seen this problem in my life. And when asking for a specific advice, there was nothing to offer. So this patient lived in a continuous sense of despair and with a sense of abandonment. Certainly, this is a significant psychological impact when you have an uncommon clinical syndrome like this. And today, my job is to bring your attention to this uncommon food-induced clinical syndrome. For many of you, this may be a totally new entity, but for few of you, you might have seen this patient in your clinical practice. I certainly would like to know what was your clinical experience. And for presumably many who have not seen one as yet, my goal is to provide you a clinical update on this clinical syndrome. Let me illustrate this case. Let me illustrate this point by giving you a clinical case scenario. A 5-month-old infant was admitted to PICU following an acute illness. The infant presented with lethargy, sudden onset of severe emesis, and later one large watery diarrhea. Infant was clinically well when dropped to the daycare in the morning. He also fed well on a Similac infant formula 2 hours prior. When he was brought to the ER, he's obviously a sick-looking infant, ashen-colored skin, lethargic, severe dehydration, hypertensive, and incidentally was afebrile. His initial lab showed a significant neutrophilia, metabolic acidosis, methemoglobinemia. Otherwise, the pertinent clinical history was unremarkable. The child was a healthy infant, growing well, exclusively breastfed. He was diagnosed with cow milk allergy due to his previous emesis episodes. What was the clinical course? The child was admitted to PICU, treated for hypovolemic shock and possible sepsis. The sepsis workup came back normal, including a CSF in the normal range. The infant made a dramatic recovery within 24 hours of presentation. So what's your likely diagnosis? Is it a case of acute gastroenteritis with severe dehydration? Unlikely, because the clinical symptoms were very short-lasting, and the patient made a very rapid recovery, did not have any fever, other signs of infection. Acute sepsis, yes, it was a very dramatic presentation, but again, equally dramatic recovery, and with microbiological cultures being negative, again, was less likely diagnosis. Is it a case of cow's milk anaphylaxis? Certainly not, because the presentation was at least 2-3 hours after his last feed, and he did not have any other system involvement. So typically anaphylaxis would be a multi-system involvement, cutaneous, respiratory, GI, and so on and so forth, but he didn't have any of those. Is it a case of food poisoning? Food poisoning is quite uncommon in this particular age group when a child who's just infant fed formulas. Again, the recovery again is quite dramatic. Usually food poisoning will not have such a dramatic presentation. Then what is it?
FPIES.
Yes, indeed. You've taken the meat out of my talk today. This child is a case of FPIES, a food protein enterocolitis. This child was not labeled so when he was discharged from the initial hospital. He later on was readmitted around 12 to 13 months of age to our institute. Again, with a very similar dramatic presentation. He was resuscitated by the EMS, actually intubated on site because of concern of seizure, and brought to the PICU. He's during the route, his airway tube had come out. He remained extubated. He was treated aggressively with IV fluids and IV fluid resuscitation. He made a remarkable recovery within 24 hours again. And then his presumptive diagnosis was severe acute gastroenteritis with hypovolemia, with possible sepsis. And then we were consulted for this patient because of mother's concern of possible cow milk allergy. She had stopped giving him any cow's milk and she stopped breastfeeding. He was only on solids, weaning food, and was surprisingly doing well. He had no exposure to milk and dairy until that accidental exposure where the grandfather who was babysitting the child gave him a milk formula because mother was away at work. So these patients, the clinical hallmark of these patients are they present with a very dramatic clinical symptoms and also make a dramatic recovery. But if you're not aware of such entity, you're not likely to come up with this diagnosis. So what is FPIES? FPIES is a food protein induced enterocolitis, is a non-IgE mediated food allergy, characterized by delayed gastrointestinal symptoms following ingestion of culprit food. The hallmark is pronounced GI symptoms, and the symptomatology may manifest little late than usual, usually 2 to 4 hours or longer. As a result, the correlationship with that particular culprit food is often missed. But FPIES is a story of missed or delayed diagnosis. Most of these patients have at least 5 or 10 episodes before they are properly diagnosed. Otherwise, they are just investigated for other unlikely etiology diagnosis. There's definitely a low awareness amongst the primary care provider. A recent survey, which looked at the 100 odd patients with FPIES, when they did a retrospective analysis, how many of these patients had this diagnosis labeled prior to their referral? Only 22% had proper labeling of the diagnosis. Unfortunately, FPIES, there's no diagnostic test available, so it always is clinical diagnosis. Many of these patients often have unnecessary diagnosis and invasive testing, particularly endoscopies, which is probably not necessary if you make this diagnosis early during the disease. You also have to remember, FPIES is not necessarily a benign condition. The usual course is a spontaneous recovery with time, but 20% of the patients like this patient end up with severe hypovolemic shock. Recent rare cardiac arrest have also been reported, both in infants and older children. And this is a diagnosis is with a evolving. The understanding of this disease is changing and evolving. We really need to learn more about this disease to do a better job in clinical management. So how recent is this diagnosis? The first documented case likely of FPIES was published by two gentlemen, Grybowski and Powell, in 1970. It was a case of infant with cow milk FPIES. The diagnosis was not labeled as FPIES, but thought to be a milk intolerance or probably a milk-induced colitis due to recurrent episodes of dramatic symptoms and improvement after cow milk was withdrawn from the child's diet. In 1970s, the disease was thought to be exceedingly rare and rarely reported. However, over a period of time, there was sporadic increasing report of FPIES, surprisingly to now not cow milk, but variety of solid food, including like rice, chicken, green peas. More reports were published for older children, so no longer it was necessarily a disease of infants. In 2012, a first documented case of scallop-induced FPIE was reported in adult, proven with an oral challenge. Recently, most of the food associated with FPIES are thought to be innocent food, not the big 8, which cause severe allergic reactions. But recently, in 2020s, there's a new kid in the block. Peanut and egg have been increasingly reported as a cause of FPIES. We do not know a reason for this, but perhaps the new recent recommendation of infant food feeding guidelines, which recommend early introduction of even highly allergenic food, including peanut, in young infants between 4 to 6 months of age to prevent a development of food allergy. So early introduction of food, you develop tolerance to food allergy, but do you create a new problem? Are you going to see more FPIES in this patient? That needs to be elaborated properly. So what the landscape of FPIES have changed from 1970s. Now we know probably any food can cause FPIES. The common ones are cereal grains, vegetable, most commonly sweet potato, carrot, fruits, and fruits like banana, avocado, apple, or other solid food, typically in older children, including seafood, peanut, nut, and eggs. What has changed in the literature? If you look at the curve of publication in a peer-reviewed journal, nothing was known until almost 2000, 2010. It's only in the past decade or so, there has been surge of a scientific publication in peer-reviewed journal. Most of these articles are emphasizing on the clinical elements. What is the epidemiological aspects of FPIES, the clinical profile of patients, and many of them also have looked at longitudinal data about what is the outcome of patients with FPIES. None of them have touched on pathophysiology of FPIES. I'd say I did talk to you about what is the quality of lifestyle for patients, a parent or caregiver with FPIES. And as a result of being ignored by the medical fraternity, the caregivers established an organization called FPIES organization. It's established in the United States, but now it has a worldwide membership. International FPIES is a non-profit organization which is dedicated its time for patient advocacy and research funding, and with the purpose of increasing dissemination of knowledge about FPIES and educating caregivers and provide them the support they need to take care of children with FPIES. It's only until 2016 there's an ICD code for FPIES established. Thus, the disease got a name, it got an established diagnosis, and now, even for research purposes, we could look back, do a retrospective analysis using this coding for FPIES. There were various diagnostic criteria proposed by different researchers, creating a lot of confusion. What is the right criteria for diagnosis of FPIES? Particularly so because FPIES is a clinical condition. So all the experts came together and they published the consensus guideline in 2017 for diagnosis and clinical management of FPIES, which was the first scientific publication really facilitating clinical care of FPIES. It's only until 2022, a first NIH grant was offered to a Boston Children's Hospital group to study the pathology of FPIES. In 2023, the Consortium for Food Allergy, which is an organization heavily involved in research in food allergy, now also included FPIES under the umbrella for further investigation. So the future looks promising because there is more involvement of scientific community now to understand the disease of FPIES and help with clinical management for our patients. A recent publication by the NIAID group, a workshop report of FPIES was published in 2025, February, stating the current status and future direction in management of FPIES. So what is the prevalence of FPIES in the United States? It is estimated 0.51% of the pediatric population may have a diagnosis of FPIES. That means there are about 375,000 children running around somewhere waiting to come to your office with this clinical symptomatology. And hopefully we should not miss this patient with an erroneous diagnosis. There are about prevalence in adult population is about 0.22%, estimated 550,000 of adults with FPIES. So it's reasonably not an uncommon disease. FPIES is prevalent worldwide. There's a significant variation in prevalence. More importantly, the food which triggers FPIES symptoms. For example, FPIES with soy is almost not reported outside the United States. In Japan, egg is the most common food trigger. In Mediterranean climate, like Spain, Italy, seafood is the most common culprit. In Australia, cereal grains is a common culprit. So there is a variation. There is an international drive about learning about this disease entity, and the International FPIE organization helps coordinate this research work. The impact of FPIES is significant. It can cause a severe effect on the growth of a child, largely due to eating disorder a child might develop because of delay in introduction of solid food. Also, avoiding nutrient-dense food can result in nutrient insufficiency, causing growth alteration. So you have to remember there's impact of FPIES in development of an infant. The most important effect we talked about is quality of life. there is significant impairment in the mental health of a caregiver, increased occurrence of anxiety, stress, poor quality of life, and decreased self-efficacy in taking care of patients with children with FPIES. Of course, it creates a lot of financial burden because often the parent have to lose their job, stay home to take care of the child, and look for alternate, more expensive types of formulas or diet, causing a significant financial burden. In fact, a recent study showed that the health quality of life of caregivers of children with FPIES have much worse quality measure compared to caregivers of children with food allergy in all domain and also in specific domain of measure of quality of life. So therefore, it's a silent disease causing problems which need to be recognized, and that also should be a part of our care to make sure the mental well-being of the caregiver is taken care of. How do you diagnose FPIES? Powell was the first person who associated the food trigger causing FPIES. So if you give that culprit food, you have symptoms, you remove the food, your symptoms are improved, and at a later time, if you reintroduce the food, the symptoms reoccur. So there are numerous other diagnostic criteria established by various authors. In 2017, the International Consensus Guideline published the first consensus criteria for diagnosis of FPIES. So this criteria essentially was clinical, and that's important because FPIES is a clinical diagnosis. You need appropriate clinical criteria to make this diagnosis. The guidelines recommended for diagnosis of FPIES, you need to have 2 major criterion and at least 3 of the minor criteria. The 2 criterion are occurrence of symptoms, delayed GI symptoms within 1 to 4 hours after ingestion of suspect food. Most importantly, it is not an anaphylaxis, it's not an IgE mediated. So there should not be any evidence of an IgE mediated reaction like hives, angioedema, cough, throat closure symptoms, and other significant systemic symptoms. The minor criteria are much more fulfilling for a severe manifestation. Like if you have a presentation with hypertension, hypothermia, a patient need to be seen in emergency room, requires IV fluids, or has extreme lethargy and pallor, the diagnosis becomes pretty easy if you know about the disease entity. If you have another episode in the past, then your suspicion is significantly increased. Or if the patient has another food trigger for FPIE symptoms, the diagnosis might be easier. This diagnosis criteria work very well for severe FPIES, but I have my reservation. Patients with milder form of FPIES might be missing, will not be diagnosed by using this criteria. And there is a spectrum of patients with milder phenotype. The most important thing is the patient, apart from these acute illnesses, are normal and well-growing infants without any other problem, as long as the offending food agent is avoided. There's also an entity called chronic FPIES. This is a little wishy-washy. There's no clear clarity on this. Largely, it states that the symptoms are long-lasting. It could manifest as a severe presentation, where the offending agent is not avoided and ingested on a regular basis. A child may have a persistent and a progressive vomiting and a diarrhea, often with blood, sometimes with dehydration and metabolic acidosis. A milder version of this chronic FPIES may have intermittent episodes of vomiting and diarrhea. The most important thing is patients with chronic FPIES will definitely have poor weight gain, failure to thrive, even without dehydration and metabolic acidosis. So that's a marker if you're dealing with a patient with chronic FPIES. But I believe many of these patients will be worked up more for malabsorption or a chronic gastrointestinal disease before we might think about chronic FPIES. Other important criteria is even after you withdraw the incriminating food agent, the recovery is not rapid. It may take 3 or 10 or longer days for the recovery to occur. Many of these patients with chronic FPIES, if properly diagnosed, and if you reintroduce that culprit food, they can manifest as an acute FPIES. So the phenotype might change after avoidance of food for a long period of time. Chronic F-PIES, some of the important highlights is almost never seen outside the infancy age group. It has not been reported with solid food. Exclusively, it's related to cow's milk and soy. So that at least is a little less concerning feature. At least we would be able to diagnose F-PIES in young infants. But the common story is there's often a delay in diagnosis, resulting in a prolonged and progressive course until the food is eliminated. So the guidelines have tried to establish a clinical profile based on the symptomatology to identify, are there any particular phenotypes in the clinical observation of all the cases? When they reviewed the literature and looked at all the case reports in the case series and the case cohort studies, they wanted to find out a pattern. Is there a certain clinical characteristic which you have? Does it affect the clinical outcome and the course of the disease? So that's called phenotype. Any observable clinical features which can be identifiable and can be correlated to the endotype or the pathology of F-PIES. So broadly, they propose 4 different phenotypes for F-PIES. One, depending on the age of onset. So there's a different outcome for patients who present earlier than 9 months of age compared to 9 months of age, more than 9 months of age. Definitely the older children and adults have a different profile and outcome in terms of their F-PIE disease. Other phenotype was based on the severity. Like a lot of these patients will present with a very severe presentation like the one I presented, or could be a milder version. That based upon, like we talked about, acute versus chronic F-PIES. There's another entity observed in this phenotype evaluation. Patients had IgE positivity. That means the skin prick test or the serum Ig test for the food was positive. This was called as an atypical F-PIES. So about 5 to 30% of the patients with F-PIES can have a positive IgE test. What it showed that these patients with atypical F-PIES generally had a protracted, sometimes unresolved course. That means the disease symptoms really lasted for a longer period of time. And not surprisingly, about 25% of patients developed true type 1 or IgE mediated allergic reactions. So is this indeed a separate profile, or as we have learned over a period of time, not only the prevalence of F-PIES has increased, but also the IgE mediated diseases like allergic rhinitis, atopic dermatitis, allergic asthma. So is this a cause effect, or this is just the 2 entities being observed together is not known. So a typical phenotype of an infant F-PIES would be an infant with cow milk and soy is likely to present before 6 months of age. If they present earlier than that, they are likely to have more of lower GI symptoms like diarrhea, including blood in the stool, and likely to have failure to thrive. Most of the F-PIE food symptoms occur with a direct feed, meaning the child has to eat the food to develop symptoms. And typically would occur in the initial introduction. Most studies show that manifestation of F-PIE have occurred within the first 4 to 8 initial feeds. So that's a little comforting. If a child has been eating food at least 10 or 12 times or more, it's less likely to develop F-PIES. A solid F-PIES manifests little later in infancy, between 6 to 12 months of age, with a mean of 5 to 7 months. Most solid F-PIES, the common food is cereal grains. Rice and oat is the most common in the United States. Other solid F-PIES are fish, egg, and poultry. Usually chicken is considered to be low allergenic food, but chicken F-PIES are much more commoner than other poultry. F-PIES in older child and adult, increasing reports of F-PIES in older age group. Most present with acute F-PIES. A chronic F-PIES is almost not known in older child or adult. They typically manifest with symptoms with predominant abdominal cramps or pain. That's a very common symptomatology. Nausea and vomiting is also accompanying these symptoms. So often these older children or adult will be misdiagnosed. Sometimes you would think it's a food poisoning or food intolerance and may not pay attention that this is indeed could be an FPIES. The key observation with findings is more common in female population. Again, same old story, misdiagnosis until the patient had anywhere from 6 to 15 episodes. Definitely, it's much more persistent. Very few are likely to develop tolerance over time. Incidentally, there was higher rates of comorbid GI conditions like irritable bowel syndrome or celiac disease in this patient population. The most common food trigger is shellfish, mollusk, or fish. So seafood are the most common, and followed by egg and also mushroom. Many of these patients might be misdiagnosed as mushroom toxicity or poisoning, so be mindful of that. So what are the food triggers for FPIES? Virtually any food is possible trigger. It varies with the geographical variation and the dietary habits of that area. Most common are the single food FPIES, amounting average around 60% of the patient population. However, the single food FPIE is not so common in the United States. Usually two food, a cow milk or a soy with oat or a rice, seems to be the most common combination in the United States. Some of the patients, almost 10% of the patient can have multiple food FPIES ranging from 2 to 13 food, bad situation. We do not understand the risk factor for multiple food FPIES. A small study of Australian infants showed that if the infant had a reaction very early age, or if they have FPIES to fruit and vegetable and rice, more likely to develop multiple other food FPIES. So just to recapitulate, I mean, acute FPIES in the United States, the common triggers are cow's milk, soy, grains including rice and oat, egg, fruit, and vegetables. In Europe, it's cow's milk, fish, egg, grain, soy. In Australia, rice, cow's milk, egg, oat, and poultry. Chronic FPIES, just infant formulas. That's it. Interestingly, many food co-associations have been noted in children with FPIES. For example, if you have cow milk FPIES, almost 40% chance you'll also react to soy. So that's not a good substitute when you have a cow's milk FPIES. The probable alternates are either a hydrolyzed, extremely hydrolyzed formulas or amino acid-based formula for infants. If you have solid food FPIES, there's almost a 45% chance you may have another solid food FPIES, is the observation. These are all earlier studies, so I'm sure this co-association may be different with time, with as we know about more study on this aspect. If you have FPIES to grain, more likely react to another grain is up to 50%. Similarly for poultry, almost 40%. So if you have FPIES to chicken, turkey, quail, and whatnot would not be a good alternate. What about FPIES in a breastfed infant? So there's very limited data, but clearly it's very, very uncommon. In fact, the European Academy of Allergy, Immunology, and our American Academy of Allergy, Asthma, and Immunology have put out a position statement stating that it's uncommon to see FPIES in exclusively breastfed infants. There is no need to recommend any maternal allergen avoidance in asymptomatic infant. Rarely, an exclusion in maternal diet might be effective, but generally not recommended. So be careful when you're seeing a patient and your suspicion is FPIES. It's not likely because of the breastfeeding. It could be some other agent which you have not recognized. What is FPIES pathology? What do we know of? All I can say, we really don't know anything about it. I could just say that and move to the next slide. But I'm just going to recapitulate a few things which is thought to be probably a proposed mechanism. It's clearly an interaction between the immune system, the GI tract, and autonomic nervous system, although we do not know the exact details. It is presumptively, it is thought that there is some disruption in the intestinal barrier, which causes leak of the protein, activation of local immune system. There's a big role for neuroimmune system there, which triggers signaling of the vagal nerve, triggering the vomiting center in the brain. If you have a lot of vomiting and diarrhea, you have hypovolemia, that activates the autonomic nervous system to maintain the homeostasis. So we really don't understand very well. There is no evidence of any systemic inflammatory changes. For example, in patients with food allergies, you can identify IgE in the blood, or you can find some T cell clones specific to that food antigen as an evidence of food allergies, but none of that is evident in the blood of these patients. So the best explanation is there is some local inflammatory process. Probably innate immunity plays an important role, including monocytes, macrophages, and neutrophil. The stress causes release of cortisol, causing increased margination of neutrophil in the blood, and that's what you see as neutrophilic leukocytosis. There is a significant proliferation of lymphocytes, but it's a pan T cell activation, meaning there's not one type of T cell. It could be Th1, Th2, Th17, Th22, which are all involved in inflammatory responses in the gut. Perhaps there's a role of mast cell also. But what has been shown that serotonin probably plays an important role in clinical manifestation of FPIES. Serotonin is a mediator released by specialized cells in the intestinal epithelium called enteroendocrine cells. The receptors for serotonin is a 5-HT3 receptor, which is expressed in multiple cells, including lymphocytes, macrophage, immune cells, intestinal epithelial cells, which are important for fluid and ion exchange across the epithelium, on the afferent nerves of spinal cord, vagus nerve, which are important mediator of vomiting sensation. So serotonin has a role in GI motility, when I say GI, gut secretions, gut motility, perception of nausea, vomiting, and abdominal pain. I'm saying so because there is one drug which is now used to treat FPIES acute symptom called ondansetron, which had been used for longest time to treat vomiting with chemotherapy or even gastroenteritis. But this drug has been used for FPIES, and in acute FPIES symptoms seem to dramatically resolve with use of ondansetron. So perhaps because it's a serotonin receptor antagonist, so probably there's a big role for serotonin, which needs to be looked at carefully in the pathophysiology of FPIES. How do you diagnose FPIES? There are no laboratory markers. There are no lab tests to confirm FPIES. It's essentially a clinical diagnosis. But you could probably do what is called an oral food challenge, which typically is done by allergists in their office. It is a medical procedure in which food is eaten slowly in a gradually increasing amounts under medical supervision to accurately diagnose or rule out a true food allergies. So we commonly do this for our patients with IgE-mediated food allergies. It's very challenging. It's very difficult. It's very resourceful when it comes to doing oral food challenges for FPIES. It is fraught with risk. It requires hospitalization and an IV fluid access. All of that makes it a very problematic procedure. So it's not commonly done. You will have very few centers who actually perform oral food challenges for FPIES. Many of them are research center. Do we really need to do oral food challenges for patients with FPIES? If the diagnosis is very compelling, you really don't need to. But there is utility of oral food challenges, particularly when the history is unclear and when you're considering to introduce new food. A lot of these patients are caregivers extremely anxious. They're worried about introducing any new food in spite of reassurances. So perhaps they would want an oral food challenge before you can introduce a new food. Obviously, it's very important to determine whether the disease resolution has occurred. So these are the two areas where there's a big role for oral food challenges. Obviously, you have to sit down and discuss with the patient and caregiver. It's always going to be a shared decision because the risk involved in performing an FPIES. There is no established accepted protocol. This is an example of oral food challenge. Obviously, it's only done under supervision of an MD with an IV access. You need to continuously monitor the vital signs. The initial step includes administration of protein in a quantity of 0.06 to 0.6 kilogram of the body weight in a 3 equal doses. You should not exceed more than exceed more than 3 grams of total protein because of fear of severe reactions. You have to wait at least for 2 to 3 hours. And then the second step would be administer age-appropriate serving of that particular food and then monitor for further 6 hours. So invariably, you need to hospitalize this patient for observation. More than 50% of patients will get a serious, severe reaction if the challenge is positive, requiring IV fluids and multiple medications. So bottom line, oral food challenges are not easy to do, not easily performed. Not many people are doing it, but always a consideration when the need is appropriate. What are the management FPIs include? Essentially a management of acute symptoms, depending upon the severity, IV fluid resuscitation, and administration of ondansetron has significantly improved outcome of patient during the acute manifestation. Just like epinephrine is necessary for anaphylaxis, ondansetron is necessary when your clinical suspicion is acute FPIs. You should be observing this patient at least for 6 hours after the last clinical reaction before being sent home, and they should have a normal clinical symptomatology before you would send this patient home. We talked about ondansetron. It's only recommended for infants more than 6 months of age. There is no safety data for younger infants. It can be administered orally at home, IV, intramuscular. Although it's a very promising drug, it's poorly studied in this patient population. You have to be mindful of cardiac disease, particularly if there are prolonged QTC interval. Arrhythmogenic effects of ondansetron have been shown. Also, patients who are taking certain drug which can prolong QTC, including a variety of antifungal macrolide antibiotics, should be a consideration. All patients with FPI should get a home action plan, just like we have asthma action plan or anaphylaxis action plan. FPI patients should also get a plan to take care of reactions at home. Particular patients with a severe previous reaction, activating EMS services is important and early, even though they might have given oral ondansetron to curb the symptoms. Most patient moderate symptoms should go to ER. Patients with mild symptoms, that means 1 or 2 episodes of vomiting, no lethargy, and in the past had recovered at home, probably could stay home and continue with vigorous oral rehydration. What is the long-term management of FPIs? Essentially, avoid primary trigger. Food elimination is the essence of treatment of FPIs because you don't want to keep provoking this clinical reaction. Continued reassurance, monitoring for growth and development. You need to seek advice of a nutritionist to provide a proper complementary diet for the infants. Enrolling in a peer group support services like the International FPI Organization is a great idea for patients with FPIs. All these patients should be periodically evaluated for IgE sensitization or for consideration of oral challenges. There are some empiric guidelines not based upon solid evidence, but on expert opinion, which recommend how you can introduce variety of weaning food in young infants. You need to select low-risk food like vegetables, fruits like blueberries, strawberries, or meat like lamb, or cereals like quinoa or other millets. Tree nuts and seed butter seem to be more tolerant in patients with FPIs at particular appropriate age group. The guidelines recommend that any new food introduced should be given over a period of 5 to 10 days. So an example of a new food introduction could be start with 1/4 teaspoonful at 9 a.m., repeat after 6 hours. You need to wait for 6 hours because that's a time period of clinical manifestation of FPIs. And the next would be 6 hours later of double the size. Keep doubling the size in consequent days until the child is able to eat appropriate portion. The natural history of FPIs is in 60 to 70% of patients will have resolution of the symptoms spontaneously. We do not have a good data about solid FPIs. Atypical FPIs do not resolve timely. So there are numerous clinical retrospective studies looked at time period of resolution of clinical symptoms with specific food. For example, Kobe et al. Reported that patients with cow milk allergies, about 5.1 had a resolution, patients with cow milk allergy had a complete resolution by 5 years of age, soy 6.7, rice 4.7, and so on and so forth. So there's a different population, the outcome has been different, but it is expected most patients with classic FPIES would make a recovery with time. Of course, when we know some things, we do not know a lot of things. And there's a long list of things we really don't know, which is a problem, because these are the various unmet needs of patients with FPIES, be it for identifying the phenotype, knowing the triggers, knowing the diagnosis and proper management, and understanding the psychosocial impact of patient for the caregivers. So essentially, to just summarize, I want you to be alert and be able to diagnose patients with FPIES, particularly patients who present with medical emergencies. It is always a challenge, going to be a challenge, to diagnose patients with chronic FPIES. There is no diagnostic laboratory test you could do. It has to be a high index of clinical suspicion to make a successful diagnosis of clinically of FPIES. It is important that you recognize this entity early in the child's life to improve their long-term outcome and to get appropriate recommendations. You need to seek help of nutritionists and support organization to improve the comprehensive well-being of the caretaker and the child. These patients need to be monitored periodically for consideration of oral food challenges. It's an evolving science. We'll have more information with time, with better criteria and recommendations for clinical management of FPIES. With this, I'm going to end, and I will be happy to take any questions. I appreciate your attention. If anybody wants to send me questions as an afterthought, I put out my email here, mpansare@dmc.org. I'll be happy to respond. So how many of you have seen patients with FPIES, and what was your clinical experience? Can somebody chime in on that? And of course, I'm ready for any questions, if any.
Thank you, Dr. Pansare, for that, introducing us to the new concepts of FPIES. Let's see if anybody has any questions, comments. They can either put them in the chat box or they can ask you directly.
So I have a question or
yes.
a comment. I actually have experience, with someone having FPIES, which is why you described it perfectly in the opening case. I was like, okay, that's it. But I'm thinking that if it's not milk or something that could need to be part of your life often, what most people would do is avoid the trigger, and they wouldn't feel that it would be important to re-challenge themselves because they could just avoid the food. The food that I had experience with the patient in was sweet potatoes. And so they're successfully able to avoid sweet potatoes. And I don't think they feel like going through that vomiting, bloody diarrhea, kind of shock-like experience. And so they can do that. But I think it really then is a comment on, you don't really know how often this occurs or resolves, because there are a certain number of people that, are out there, and they're just not going to re-challenge themselves.
You're absolutely right. That's a very judicious comment. Exactly, that's what happens in real life. Patients, particularly if they have seen a doctor who could not establish this diagnosis, if there's no name tag given to it, they are always confused, and they know this food has been causing me a problem. Why should I be re-exposing my child to go through all that trouble? So they would just continue to avoid that. And until they meet a person who could reassure them, things change with time. Maybe we can reconsider. It's a matter of gaining the confidence and talking to them, explaining to them what usual outcome is with whatever little we know, perhaps would change their mindset. But there's no way any parent is going to just say, I want to try this again, because they know you like it or not, doc, I'm not going to listen to you. This is my experience. You tell me whatever, I'm not going to do that. And this is exactly what happened to us. We have some certain patients. I may have 4 or 5 patients only in my practice, and 2 of them I wanted to do a challenge, but they say, doc, I don't want to do it now. Maybe when the child is older. It's another way of telling me I'm not interested. They don't want to tell me, no, I don't want to do it. But I totally understand that, So there is a role of oral food challenge for such patients, but whether they will be willing to do it, because oral food challenge is a supervised test. It's a sort of a medical procedure. So at least that benefit they will have rather than, go eat at home, which they never would do.
Sure.
So yes, but we have to keep talking about this, reassuring a patient, know them this is what you have, this is what is expected to happen in spite of our limited knowledge. But that might change their mindset, and perhaps they might be willing to do re-exposures.
And thank you. Excellent talk.
Thank you. There is I will come back to you, Dr. Brooks, but there is a question in the chat box. What are stool calprotectin and stool alpha 1 antitrypsin levels in stool during the episode of F5s?
So there's a limited information in that at all. So these are like a acute phase reactant in the blood. People have noticed with inflammation in the gut, certain markers are released, but nobody has looked at particularly using those two proteins to look into the stool. At the most, people have looked at stool eosinophils, stool leukocytes and whatnot. But FPIs, when nobody has done biopsies for patients with FPIs, obviously you're not likely to do it because it's such an acute manifestation and dramatic recovery. You are not likely to do any endoscopy and biopsy for these patients. Maybe for chronic FPIs because you want to rule out other gastrointestinal disease. So we really don't have a data. Whatever few times people have done an endoscopy, all they have found was non-specific changes, some sort of damage to the villi, but nothing observable. So also, there is no evidence, bottom line, of looking at these two items as inflammatory markers in FPIs. Whether FPIs is an inflammatory disease, we don't know. But once we learn, like I said, there was a recently NIH grant in trying to investigate the pathology of FPIs. Perhaps once we know better, people will start looking at different markers for FPIs. But that's an excellent thought. I mean, that's a very astute observation. Is there a role for such stool studies?
Thank you, Dr. Pansare. Dr. Brooks, go ahead, ask your question or make your comments.
I just want to thank you for an excellent description. I was first introduced to this disease when I was a fellow in allergy immunology some years ago, and the child was worked up for bloody gastroenteritis by a gastroenterology. We finally determined he did have a milk allergy and resolved. And back then we called it allergic gastroenteritis. Yes. And I took it upon myself after he was a year or two to do an oral challenge. And he had exactly what you described. He had a massive bloody diarrhea about an hour or two after the challenge, and became pale and hypotensive and lethargic. So I'll never forget this disease. So thank you so much.
I can guarantee you're not going to forget, because you see this once, you're going to remember it lifetime. And you really want to, you will feel more curious about this disease, because really it's unfortunate that these patients out there without any labeling, and they do not because they're not labeled, then they're not told what can potentially happen, which is a very risky proposition. But I appreciate your insight.
Any other questions, comments for Dr. Pansare? So, Milind, you said that about 25% of the patients have IgE elevated or specific to particular food?
Yes. So IgE for the specific food, which triggers the symptoms.
So, and are they still considered a part of FPIs?
So, yes.
It's not type 1 reaction?
No. So what has been shown in epidemiological studies, these patients had a positive test. So positive test means they're sensitized. That means they do not have clinical symptomatology, but many such patients do develop actual type 1 reactions with time. So that's why we as an allergist, if I'm going to do oral food challenge or so for FPIs, I will do a skin prick test or serum IgE testing for the particular food, because there's a risk of clinical reaction for these patients with time too. So we do not know really how often this translates into true clinical reaction, but certainly we are learning there's increasing risk for these patients, particularly who have atypical or Ig positive phenotype. Time will tell us, more studies will tell us what actually happens to this patient. But yes, it was not thought about, but there's a risk for these patients who are categorized as atypical FPIs. And like I said before, we do not know if this is really a special phenotype, or is it because they also have comorbid atopic diseases, that they have atopic dermatitis, allergic rhinitis. And we know that a lot of patients with atopic dermatitis will have a false positive test because that's what the nature of the disease is. So many patients with eczema, if you do serum Ig testing, whatever you test for will come out as positive. Is because they have such a high Ig level that they non-specifically bind to food antigens in your lab testing. So is this just a false positive test, or are these patients really going to have a disease, or how many of them really end up with clinical symptoms is a really important information to find out. But yes, there's a potential risk.
Okay, thank you. Dr. Brooks, do you have more questions, comments?
No, sorry, I just left my hand up.
Anybody else has any questions, comments for Dr. Pansare?
I really appreciate your attention, and I'm really sorry for the glitch, the technological glitch we had. Unfortunately, I'm unable to see any one of you. It's just my screen, but I'm glad we were able to communicate.
Thank you.
Virtually.
Thank you, Dr. Pansare, for that fascinating presentation on FPIs. Really appreciate it. Thank you all for attending this morning's grand round. I'm going to conclude and see you all next week, Friday at 7:30 in the morning. Thank you all. Thank you, Dr. Pansare.
Appreciate it.
Bye-bye.
Bye-bye. Have a good weekend, good Friday. Enjoy the cheese day.